Sandy and Ash, thanks for moderating tonight. When you two are ready, let's go ahead and kick this off.
Great.
All right, should I go ahead?
Yes, please.
All right, well, first I'd like to welcome everyone to the MVSS webinar series, Venous Thromboembolism, Iliofemoral DVT Therapies, IVC Filter Management, and IVC Reconstructions. First, I'd like to acknowledge Penumbra for sponsoring our January webinar. We appreciate their support. Our first speaker is Andrea Obi. She's Assistant Professor of Vascular Surgery and is Co-Director of Venous Health Program at the University of Michigan. Her research focuses on the immune-based mechanisms of venous thrombus resolution. And she's going to start us off today by talking about iliofemoral DVT, the scope of the problem, and who to treat with endovascular options. So thank you, Dr. Obi.
Thank you so much for that introduction. I really enjoy these webinars and I really appreciate the invitation. I always learn something new. These are my disclosures. I'm going to talk a little bit today about the overall scope of the problem of VTE and the morbidity of iliofemoral DVT specifically, the goal of interventional therapies, and then how we determine within our hospital system who should qualify or who should get an intervention. As we all know, VTE is a really common problem in the United States. It affects about 900,000 patients per year. If you are a football fan, you may recognize this as being the Big House, the largest collegiate football stadium in the United States. It holds about 114,000 people. You can imagine this filled 8 times over with patients. This is how many people are affected by VTE yearly. I have to give credit to my mentor, Tom Wakefield, for this slide. And fully 3 full stadiums die from this disease every year. Besides being a mortal disease, it's a pretty expensive disease. You can see in 2012, about $70 billion were spent caring for patients with acute VTE. And this number only continues to rise with the widespread adoption of DOACs. You can see that Medicare Part D spending, apixaban alone accounted for about $5 billion of prescription costs in the US. And that was in 2019. When we talk about the goals of therapy for VTE and iliofemoral DVT in particular, they're really threefold. So the first is to prevent extension or recurrence of deep venous thrombosis. The second is to prevent pulmonary embolism and mortality. And the third is really to minimize the late sequelae of thrombosis. And what I mean by that are limb symptoms. Anticoagulants accomplish the first 2 goals pretty well, and I'll show some data on the next slide regarding those outcomes. But they don't really do a great job at accomplishing number 3. And this is really where the role of endovascular therapies can come into play and help prevent long-term symptoms in our patients. You can see that anticoagulation works pretty well for those first 2 problems, but it comes at the risk of major bleeding of about 3%, so it's not perfect. We know that VTE recurrence is a common problem. It's really high in patients who have no or very minor risk factors, and it tends to rise as anticoagulation is stopped. One of the independent risk factors for VTE recurrence is residual venous thrombosis. And this is where, at least in theory, endovascular therapies could potentially help our patients by removing that nidus that can cause a recurrence down the road. When we talk about these limb symptoms or post-thrombotic syndrome, what we're really talking about is the outcome of 2 pathophysiologic processes: venous obstruction from the residual thrombus causing venous hypertension, and venous fibrosis causing valvular damage. Really, there's no widely effective treatment for these valvular issues currently. And so our only method to help our patients in terms of preventing post-thrombotic syndrome is by removing the thrombus. And as we'll hear at the next talk, there's a whole variety now of sophisticated endovascular techniques to help our patients with that. PTS is a major problem. It affects about 50% of patients suffering from DVT, and it's severe in 1 in 5 patients. It costs a lot of money, and ulceration, which is just one manifestation of PTS, results in about 2 million lost days of work per year in the United States. If you think about where DVT occurs across the body, iliofemoral DVT is the most morbid place to develop it. Historically, reflux and venous claudication are exceedingly common in these patients. And even in modern day series, you can see the data from the CAVA and the TRACK trials here. Development of any post-thrombotic syndrome or of severe post-thrombotic syndrome mirrors what we see in large epidemiologic studies from the past. So we really haven't made a huge amount of progress in helping these patients, which is why we need more advanced therapies. The problem with these patients really is that what we're trying to do is to prevent a disease that you really can't diagnose for about 6 months. By definition, you can't make a definitive diagnosis of post-thrombotic syndrome until that patient is about 6 months from their acute insult. So how do we determine from data that we have in the acute setting who gets an intervention? So I'll just walk through really quickly here the algorithm that we use at our institution. This is actually published. You can see at the bottom here, the PubMed ID. This is a set of clinical care guidelines that were developed about 6 years ago by our quality department after an evidence-based literature review. And we really tried to take into account across different specialties what the national guidelines were saying, what the best available evidence was, and break it down into a very granular system that our frontline providers could implement and make sure that we're treating patients equitably across the healthcare system. So what we ask anyone who encounters a proximal DVT within our healthcare system is that they immediately treat that patient with compression, elevation, anticoagulation, all the gold standard care, and that they then take a moment and identify the location of the DVT. If it's a femoral popliteal DVT, then we encourage them to treat this patient with anticoagulation alone. We don't necessarily try and capture these patients for intervention, not because these patients won't benefit, but really because we don't have a good way to identify the patients who will benefit the most. So we know that in general, recanalization in the femoral popliteal segment is normal. Up to 90% of patients have this happen by 1 year. That's not the case in the iliac system. We know that those who don't recanalize or take a long time to recanalize, as you can see from this data from Dr. Meisner's group, are the ones that are more likely to become symptomatic. But there's really no good way. We don't have a crystal ball at this point in time to select that minority of patients who are acutely going to benefit from an intervention. And this represents a major gap in our clinical knowledge. Now, if this patient was incidentally diagnosed with a DVT, they have minimal or no symptoms, we again send these patients out with anticoagulation and close follow-up. What we really try and do is capture these patients with moderate or severe symptoms and try and get them admitted to the hospital, or we arrange for a close follow-up within our clinic to see them after a trial of anticoagulation. So we do try to trial these patients for a minimum of 48 hours on anticoagulation and then reevaluate their limb for improvement or resolution in symptoms. And why would we do something like that? Well, this really has to do with the outcomes of the TRACK trial, which we all know is a trial that randomized patients to receive the gold standard anticoagulation versus catheter-directed therapies for the treatment of acute proximal DVT. And this study initially, while it was lauded as sort of a negative trial, we know if we look at the subgroup analysis of patients with iliofemoral DVT, these patients did seem to benefit from these endovascular interventions. And you can see they all had reduced post-thrombotic syndrome and improved disease-specific quality of life with really not a major trade-off in terms of complications. If I had to pick one sort of minor issue with the trial, it's overall a very well done trial, but one of the tiny Achilles heels was that there's no real mandatory lead-in time for these patients to assess for anticoagulation response, meaning that the trial may have been more positive in favor of intervention if the patients who are great responders to anticoagulation and resolve their symptoms with anticoagulation alone were left out of the randomized cohort. So what we've tried to do with this algorithm is weed out those patients who are going to be excellent responders and will be unlikely to benefit from intervention. We then screen these patients for contraindications to lysis, and then we also have a separate list of indications for lysis. You can see here, this list is short. We do want to capture those patients with symptoms. They need to be functional. The DVT we ask involves the iliac veins and is there less than 4 weeks. We don't necessarily exclude patients if they don't have a first-time episode DVT. I imagine this will fall out in our next set of guidelines. And of course, this is all done with shared patient decision-making. As a tertiary care center, we have many patients that have relative or absolute contraindications to lytics, as I'm sure many of you do. But what if this patient comes in and they have moderate to severe symptoms and they're a good candidate and they want an intervention? How do you approach this patient? This is where I really think these mechanical thrombectomies and suction thrombectomies and one-stage procedures can really change the risk-benefit balance to be in favor of intervention. For these patients, we do additional screening. We make sure that they have adequate access, meaning no chronic infrainguinal DVT, and they have adequate inflow. We don't think they have a DVT that extends so low that we'd have to leave a lytic catheter there to achieve inflow. If that's the case, then certainly we offer these patients intervention. We just haven't built that into the algorithm yet. That needs to be redone. So I'll pause there and get excited to hear what everyone else has to say. And I want to thank everyone in our Venous Health program. Really, the bulk of this work is done by my partners in interventional radiology who treat lots of these patients. And we try and work together as a group to deliver the best care. I'm happy to give these slides to anyone or share any of this information. My email is at the bottom. Thank you.
Well, thank you very much, Dr. Obi. I want to remind everyone that if you have questions, submit your questions in the Q&A and we'll address those. I kind of wanted to start us off, though, by asking you how you ensure consistency in determining which patients have mild symptoms and which patients have moderate or more severe symptoms in that more acute phase when you're trying to identify who to treat.
Thank you so much for that question, Dr. Carr. That's a really important point, and this is going to be an area I think that we work on over the next year. Right now, what we're using is the Villalta score, and I wouldn't recommend using that for acute DVT, but really what we found when we instituted these guidelines is we just had to have a way to talk across a whole bunch of different specialties about limb symptoms. And so this gave us a starting point in terms of just recognizing what those symptoms can be and that there's a gradation in them. I imagine that we'll get into the weeds with the literature and come up with something new, but that is something to consider when you're talking about a giant healthcare system and a lot of people involved in the care of these patients. Thank you.
Well, that's excellent. And the other thing that I was wondering too is with, if we're following a lot of the guidelines and that were set up by the ATTRACT trial, are we missing a lot of patients with milder symptoms at the beginning who would likely benefit from pharmacomechanical thrombolysis or from some type of intervention? For instance, like the younger patients who have many, many years before they, would develop post-thrombotic syndrome.
I think that is a really excellent question. I think there's two sides to that coin. So one is we know that the incidence of post-thrombotic syndrome does not go down over time. So it steadily increases with the number of years the patient lives. There was a recent trial that came out, the CAVA trial. They published their long-term outcomes and didn't see any difference in their ultrasound-guided lytic therapy compared to standard of care, and looking at patients that were treated and looking at their sort of long-term outcomes. They're supposing that they're going to capture more patients that develop post-thrombotic syndrome down the road in that control group. But your point is well taken. It's a chronic disease, and it can develop over a longer time. And we certainly don't have the capability to run some of these randomized control trials out 5 or 10 years. And I think for now, that's going to be an unanswered question. I will say my one caveat, and I know I share this with some of our interventionalists with the young patient, is we don't have long-term outcomes on some of the newer stents. And even with the wall stents, there is a certain, risk of fracturing and stent distress over time. And I'll leave that to some of the other interventionalists to discuss, but that is an area where we do take a pause, is leaving an implantable in a patient who is very young and may have 60 or 80 years to live.
Oh, absolutely. And I suspect too that, that risk benefit balance may change when you're using less thrombolytics and more mechanical thrombectomy. And I am not seeing any questions from the participants in the question and answer section. So go ahead and submit your questions if you want anything answered. Otherwise, we'll move on. Well, Ash, would you like to introduce our next speaker?
Sure. So our next speaker is Mark Breuring from TriHealth, Good Sam Hospital in Cincinnati, Ohio, Dr. Muck's partner. And he's going to talk to us about management of iliofemoral DVT and acute IVC filter thrombosis. Mark?
Yeah, thank you so much for the introduction. I will be talking about the management of iliofemoral DVT and acute IVC filter thrombosis tonight. Again, trying to keep this within 8 minutes is a very tough task. So I have no financial disclosures. And again, thank you to Penumbra and MVSS for this opportunity to talk tonight. I know the pandemic has brought with it many changes and challenges that each of us face on a daily basis. One of those changes in my life has been the amount of time spent on Zoom and webinars. My wife's a pediatrician, and so between the two of us, we have quite a few meetings on a weekly basis. We also have 3 kids under the age of 4, so one of the challenges that we've had to deal with is preventing unwanted guest speakers in the background. So we kind of put our heads together and decide maybe we could share some of the ways we prevent these unwanted speakers. So we submitted this to the American Academy of Pediatrics, Innovative Techniques for Childcare during webinars in a global pandemic. And for some reason it was quickly rejected. We're not quite sure why. So, but just want to apologize if anyone pops up in the background. We were kind of running low on duct tape this week. But as Andrea said, immediate management of patients with iliofemoral DVT, which I won't spend a lot of time on, consists of anticoagulation, leg compression, elevation, and then obviously if the patient has a contraindication to anticoagulation, IVC filter placement. The treatment algorithm I have here was from a review paper published in 2015, very similar to the algorithm Andrea presented. And I think, if you do a search for treatment algorithms of iliofemoral DVT management, you get a similar algorithm. I think something that's interesting, and again, we kind of touched on it with the last talk, is that when you get to intervention, a majority of these algorithms really only talk about catheter-directed thrombolysis and don't mention mechanical options. So, there are many different endovascular management options for the treatment of iliofemoral DVT, obviously catheter-directed thrombolytic therapy, as well as mechanical thrombectomy or pharmacomechanical thrombectomy is also an option. Catheter-directed therapy involves placing a catheter across the thrombus and instilling TPA to help resolve the thrombus or decrease the thrombus burden. This comes without problems. There are complications that occur with catheter-directed thrombolytic therapy, from access complications to probably one of the worst complications is a hemorrhagic stroke. So what endovascular options do we have that don't require TPA? There are many different options available now. I'm going to talk about two tonight that we at our institution use on a weekly basis. One is the Penumbra Lightning 12 aspiration thrombectomy device, and the other is the Inari ClotTriever. So the ClotTriever system is a mechanical thrombectomy system designed to remove large thrombus from vessels without the use of TPA, or potentially help preventing ICU stay, which is, I know, very important these days. It involves, you can see the sheath there, 13 French sheath with a nitinol funnel to help extract the thrombus. And then the catheter itself has a nitinol coring element with a woven collection bag to help collect the thrombus. I'll run through a quick case here. This is a lady that presented 2 years ago on New Year's Eve. She had 2 to 3 days of worsening left leg swelling and pain to the point where now she's having a difficult time walking. She's actually an employee in our healthcare system. The emergency medicine team had worked her up and performed a venous duplex, which confirmed lower extremity DVT. And they also got a CT venogram, which showed likely compression of her left common iliac vein. Discussing options with her, she was deathly scared of any of the complications of TPA. So we explained, we'd attempt to intervene on her, given her significant symptoms and overall high functioning lifestyle, and if able, try to do single session therapy. So she was placed in the prone position. We originally accessed the popliteal vein with an 8 French sheath and performed a venogram as well as intravascular ultrasound. The venograms are on here. I'll kind of run this through for you. Confirming the findings on the venous duplex and the CT venogram. We used the Inari ClotTriever and was able to, after about 6 passes, remove a significant amount of acute and what appears to be organized thrombus here. We used intravascular ultrasound to confirm the presence of a greater than 50% reduction in the diameter of the common iliac vein by compression of the artery. We used a venous stent to stent this, and then follow-up venogram here shows she now has excellent flow through her iliac system into her vena cava. She said her leg felt almost immediately better. The next morning, her swelling had gone down significantly and she was walking without pain, was discharged that next day. Penumbra is another device that we use almost every other day, it feels like these days, but patients that, it's an aspiration thrombectomy catheter used to remove thrombus from arteries and veins. It's robust, trackable, and is atraumatic. Originally, the Penumbra engine was always on continuous aspiration, which could lead to blood loss, increased blood loss. The nice thing about the new Lightning system is that it can detect whether the catheter is in flowing blood versus thrombus. When it's in flowing blood, it goes on intermittent aspiration. When it has encountered thrombus, it goes on continuous to help remove the thrombus and decrease overall blood loss. So this is a gentleman, 63-year-old, who came in very similar to the last lady. This guy had 2 to 3 days of left lower extremity swelling. It progressed into pain and now difficulty walking. Again, the emergency medicine team had performed a venous duplex and CT venogram, which showed lower extremity DVT as well as compression of his left iliac vein. He is someone that also we felt would benefit from intervention. So again, in prone position, we accessed the popliteal vein, placed an 8 French sheath, confirmed these findings with a venogram. You can see the images here. And then decided to intervene. Again, he did not want TPA if possible. So using the Penumbra Lightning 12 system, we were able to perform aspiration thrombectomy. The video on the right, as it plays through, you can see the catheter itself kind of jump through the stenosis with how tight that stenosis actually was. And then here's some pictures of the thrombus that were removed using the Penumbra device. Post-procedurally, here's a venogram of the femoral vein. You can see good flow. And then just to kind of show the amount of thrombus that we removed with the device, you can see here laid out on the table. We performed intravascular ultrasound, again confirming the presence of a greater than 50% reduction on the left, and then on the right is post-stenting. And follow-up venograms show good flow through the femoral vein, as well as the iliac system with the iliac vein stent in place. Again, this guy had tremendous relief of his symptoms even the next day, and was up walking without any difficulty, was discharged the next day. Here's just last week, another case of a patient that came in. This guy came in the same day his symptoms started. The first 3 pictures are pre-intervention, and then the last 2 are post-intervention. And again, this was with 1 single pass using the Penumbra Lightning 12 device. I think we lost less than 50 cc's of blood on this. Quickly, I'll just touch on IVC thrombosis. Obviously, oftentimes it's related to IVC filter placement. This is a patient that came in with bilateral lower extremity edema and pain. CT venogram shows the previously placed tulip IVC filter with thrombus throughout the IVC and iliac venous system. We felt she was a good candidate for intervention as she was a very functional individual. This is showing the Penumbra aspiration catheter easily tracking through that filter, performing aspiration thrombectomy. Again, this is the contralateral side. And then at 1 month, here's a picture, here's a CAT scan that we obtained showing that the IVC is patent with no apparent residual thrombus. So, during the last discussion, we kind of talked about what is the role, what roles do we have with these new and ever improving mechanical thrombectomy devices. And I think that's something that's going to be important for us to evaluate and present our data to each other to help come up with a better algorithm to hopefully improve patients' symptoms and overall status. This is our results with the first 16 patients we used the Lightning 12 device on. And you can see we are 94% successful with single session therapy, minimal blood loss, no hematomas, mortalities, anything like that. So I think it's going to be very important for all of us to hopefully improve our data to use these devices in patients to help prevent worse outcomes down the road. So thank you, MVSS, obviously for letting me talk today, and all my partners for their support with these cases.
Nice job, Mark. There's a question in the chat about whether you place an IVC filter above the one that you're trying to thrombectomize. Could you address that?
One, crossing the lesion and then performing aspiration thrombectomy as you pull back through the thrombus segment. Some of them I'll start distally and work my way through it, but no, I don't routinely place an IVC filter.
The other question I had was the two cases you presented, you did popliteal access with the patient prone. And I'm wondering, in your experience, are there any patients that can't tolerate being prone for a while? And when do you do the same thing and just access the groin?
I think it depends from my standpoint how extensive the lower extremity the DVT is. Obviously, Andrea had mentioned an important thing for them when they offer these patients mechanical thrombectomy is access. Another option that we have employed is accessing the posterior tibial vein and working from there as well. So popliteal is what I personally use if the patient's able to lay prone and the access looks good. But yeah, you're right. We do have other options, and it all just kind of depends on what the access looks like. And we'll check that before we actually do the procedure with ultrasound and make sure we don't have good access.
Great, thank you so much. Sandy, back to you.
Oh, great. Okay, I'm going to introduce our next speaker, Dr. Judith Lin. She's a professor and chief of vascular surgery in the Department of Surgery at Michigan State University, College of Human Medicine. She's a busy vascular surgeon at Warren Lansing Hospital, and she has clinical interests in aortic disease, carotid disease, peripheral arterial disease, and of course, deep vein thrombosis. So her talk is going to be about IVC filter disasters, tips and tricks for endovascular and open surgical removal. So I'm looking forward to that.
Thank you so much. Hopefully less of disaster and more of a success. Thank you. So I'm going to share some, can you see this? Yes. Okay. So here are my disclosure. I don't have any financial disclosures. I am a member of the outreach committee, some of the products and devices I'm going to use are going to be off-label and not FDA approved. So I'll mention those as well. In terms of background, Dr. OB gave a really good talk about that. So there's a lot, 300,000 experienced pulmonary embolists with 12% likely death within 1 month. So there's 2,000 IVC filters in 1979, and now we have 25-fold increase to 20 years later. And then even in 2012, most of these filters placed were retrievable and more than half were placed for prophylactic. So there's been really an explosion in over 200, about 250,000 filters are placed each year. So this is a big issue, I guess, in terms of incidents. So in terms of complications of these IV filters, obviously they're very safe but some of the complications that can happen is when you get a tilt, more than 15-degree angulation from the long axis of the IVC, and that prevents it from functioning. There's also filter migration, defined as more than 3 centimeter cephalad or caudate inferior superior movement from the initial placement. Sometimes the filter can not open properly, or I've seen them in the areas like gonadal veins, or some of them in the iliac when they're not meant to be there. They were deployed too low. They can also cause cable thrombosis, and of course the filter fractures that embolize to the lung pulmonary artery. As far as perforation, we see a lot of this penetration in the walls of the aorta, maybe adjacent to the structures, and of course access site complications. So in terms of long-term, this is a study from the Kaiser Permanente group looking at IVC filters in their radiology suite. They follow them long-term. These are ones that have prolonged dwell time over the 3,300 filters that were placed with at least 4-year follow-up. What they found was with 96 patients, so pretty low complications, but 39 of them were permanent, 57 were retrievable. They were over 5 years. The fracture rate was 14% and IVC occlusion was 13%. And the perforation was known higher among retrievable devices, especially like the Cook Select, versus permanent devices like the trapeze. However, the trapeze causes more overall filter occlusion. And so there are long-term complications are pretty common. So it's nice to get them out in a timely fashion. This was out of their paper, so you can see it on every one of their devices. Can cause complication. So in terms of, this is a case of mine. I'll show some cases, and you probably have seen all this in terms of filter penetration, 46-year-old woman. It was placed prophylactically and then started developing abdominal pain for 6 years. And this one is a recovery IVC filter place. It actually was over 15 years ago, but she started developing symptoms about 10 years down the line, and you can see perforation in the area. Most of these can be done simple, so we can, usually I use the Cook sheath, retrieval sheath, which comes in a 10 French sheath. You go in and essentially go in and loop, and that's probably the most straightforward. However, a lot of these filters, after they've been about 6 months or a year, and these are the ones I get because they get lost to follow-up. Nobody knows where they are. People, they're really good about following it up. I don't want to say it's the ones that are lost to follow-up or never realize they have a filter, or somebody then told them, oh, you better get your filter checked out. Then they realize it's been like 5 to 10 years. So then they come and see me. And so then you have to start looking at advanced endovascular retrieval techniques. And in this case, I put a 16 French sheath in that. Once I can't loop it out, if I can't take it out with a 10 French sheath, I then upsize it to a 16 French sheath, and I do a loop wire snare. I want to first make sure that there's no cable thrombosis, and most of these already have a CAT scan, because if they're, I have to figure out a reason why to take them out. If, symptoms of abdominal pain or filter strut fracture and things like that. But so most of these cables are patent. I come in with a loop and essentially snare it. And usually I want to get to at least 2 or 3 leg of that strut, so I have a really good hold on it. And then you have to really advance this to make sure that this loop is inside the 16 French. If they're not lined up coaxial like that, you're not going to get them out. And a lot of these is trying to get this hook off the wall, because there can be buried. You'll see it gets just stuck. So once you tease that out, you can get it out. This is one of the examples that was placed over 5 years, and we had to use advanced retrieval. First, I make sure that the cava is open, then loop wire, and then getting the hook out. This is a Cook Hunter tulip, conical shape, pretty straightforward, but it takes some technique if you can't do with a simple technique. And this one is a 69-year-old man with retrievable IVC filter. Again, 8 years ago, lost to follow-up. A lot of these people, they say they cannot be anticoagulated, yet they're on Eliquis. So I was like, well, then you really don't need that filter. But anyways, it was in, and he had previous arterial thrombectomy and then had a DVT. So then it's a select retrievable filter. And this is actually one of the easiest filters to take out, select. Even if it's 5-10 years down the line, they are probably one of the easiest. They also causes the most amount of penetration as well. This is another one that when you have, if I can't get it out to the loop wire snare, my plan C is usually going in with the endobronchial forceps. This is where I need the long French sheath. So I get the 16 French is already ready, actually, and I make sure I have the long, rigid endobronchial forceps. So it's kind of like laparoscopic, but you got to get that jaw in there and then make sure that it's coaxial. And then sometimes I can take it out. If I can't, I have to go to the next other techniques. But in terms of looking at sort of these complicated IVC filter retrievals in 217 patients, this one I think is out of Northwestern or one of the other IR groups. The success rate is 73% for routine, but what they do is once you advance it to the advanced endovascular technique, you pretty much take most of them out. I would say you're correct, about 95 to 97% success. The retrieval complications, 1.7%, dissection, intussusception, thrombosis. We can fracture. Sometimes, it'll fracture and then it'll get embedded into the spine because it was already there and I just can't get it out of the spine. And I just end up breaking and end up leaving it there. But most of the filter is out. You can start having bleeding and of course access site complication as well. So this usually happens a little bit longer with longer dwell time. If the filter is a little bit more tilted, or the hook, if I can't get the hook from the top to get out, it's those are really the ones that are very frustrating to pull out. This one is my own data. We have 47 patients. The dwell time usually is 9 or 10 years because they kind of get lost to follow up. And the other is I got a lot of referral from the lawyers that refer the patient for me to take it out because they wanted the evidence. So sometimes they'll refer and say, hey, go find Dr. So-and-so, Dr. Lynn, to take it out, I guess. So some of these, so once we took them, most of them are women, but they're in their 50s, although we've had some really young patients. And most of these are the previous indication for is high risk despite anticoagulation. Many of them are for prophylaxis. We did take out a lot of asymptomatic ones, but a lot of patients, it's kind of hard to say if they have symptoms. They'll have back pain, abdominal pain, and then once you take it out, their symptoms are magically gone. Or maybe some of it is just, I don't want to say supertentorial, they're just very fearful of these issues with the filters. Most of them is pain, sort of very non-specific pain. Our retrieval success was 97%. Most of them were endovascular. If we can't do it endovascularly, we got to go figure out plan C, D, and E. This is one of them when I left in. He actually was contacted by a lawyer that told him he has a filter. He didn't know about it. This was placed way back when 2008. He was in the ICU and he didn't really have any symptoms, but obviously he's got this embedded into the spine, and we talked about it. And then he decided that, you know what, it's probably best to leave it be, which is fine. This is a Simon Knightnell filter. This one, 57-year-old obese woman who was going to go for gastric bypass, never really quite made it. She had a filter placed, so she's still a little bit obese. Of course, you see this filter extending out. She was actually another one of that was contacted by the litigation team, and they told her to go find somebody to take this out. So they kind of shop around. And this is one that essentially one of them strut is broke off, and you'll see a video of this actually. This is outside of the vena cava next to the colon. This right here is it's actually a permanent filter because it doesn't have that hook. Although these, if it's conical, I could still take them out if I could put the hook on, but I just didn't know how to take out this little thing. It was in the omentum area. So essentially, I'm gonna run this quickly. We were taking this out and we got right there is where where one of the struts, it's almost like a fishing expedition, but miraculously we found it pretty quick. Then we divided the gonadal vein. This is kind of, even though it's done robotically, it's the same concept with open. You have to go and get all these little side branches, lumbar branches, which is actually very difficult, but the visualization is great. And then a lot of the times the filter struts are sticking out. You can see this one was coming out by a lot. And we basically placed vessel loop proximal and distally for the control. And it's actually was sticking next to the aorta and almost the hook. These hooks are actually embedded a lot. If you and you can almost have to tease it out of the different structure. It's actually extruded into the aorta and sticking out. So you really have to also make sure that the hook, when you're not going to tease it away, you have to straighten out the hook. Otherwise, it's going to rip the vena cava. So this is why when I do it endovascularly too, I make sure I don't pull, I actually push. There's a little, and I do this by hand, by feel. It's a very delicate tactile feeling. That hook there, usually we have to straighten it out. And I usually try to do this endovascularly, but obviously if it's open, I also try to either cut the strut out or try to get it out as gently as possible. So that's, once we take it out, I'm going to fast forward this. And it's straightening that strut out. That's what's usually what takes, when you pull it out, you'll see there's always residual, even though it's mostly free. And it's also embedded. It's so difficult a lot of times. When I do the loop wire snare, if we can't take it out, we have to do another technique, which is using the laser. It's an off-label use. So is the Da Vinci robot for this. This is completely off-label, not FDA approved. So you got to know what you're doing and don't do this at home. But individually, we're pulling it out. We actually straighten the strut out first so that we're not ripping through the vena cava. And you can see it's stuck there. So this is why it's not coming out. So we either have to laser it out or we have to cut it out. And these are really chronic filters. This one is at least not nine years old. Oh, and then we do the reconstruction, which is for Gore-Tex. You can use pretty much any. I like using Gore-Tex, especially you can see better robotically. And then the reconstruction and make sure that it is tight seal. So it's the same principle as doing it open, exactly. And getting the filter out. So this is only if we can't get it out or if there's some other technical difficulty with this. And so once we remove this, there are very few indications to do open. This is out of the Houston group, Memorial Hermann Health System. Over a 6-year period, they actually removed 7 patients under open. They've tried attempted endovascularly and they weren't able to. Some of these old filters, they all have symptoms. And so this is a demonstration on who they ended up having to take it open. This one is out of the Mayo Clinic group. A 6 patient underwent open surgical removal because of, they all have strut penetration, like I demonstrated. They all have perforation into their viscera, you know, the bowel, the spine or kidney sometimes, duodenum, cable clamping, longitudinal menotomy. Some of them, they actually do a sheath. So that's pretty cool there too. So in summary, the incidence of complications associated with filter has decreased. However, many of the complications listed may be symptomatic, so it may be underreported. In 2010 and 2012, actually, the FDA issued a strong safety alert to say, please, please, please remove these filters as soon as you can. The longer the dwell time, the harder it is to remove, but we can do it. It increases the complication rate. And then for well-selected patient with appropriate follow-up, IVC filter that is safe to prevent fatal PEs with very low risk of complication. We just need the follow-up. And actually our next, the PRESERVE study is gonna come out, although it's supposed to finish last year. I don't know, the results hasn't been published to figure out the safety and efficacy of IVC filters. So thank you very much, and I'm happy to answer any questions.
Well, that is really, wow, what a cool video. One of the things I was wondering is how does your management change when you've got thrombosis of the IVC filter?
Yeah, exactly right. If I have thrombosis, I leave the filter in. Some people leave it in if it's more than 30%. And this is where the penumbra comes in. I had a patient that came in, still had the ilioceval. I used the penumbra and went up and down and just kind of clean out the vena cava, but I still left the filter in. I'm going to come back another 3 to 6 months, probably 6 months. I'll kind of wait and see. There's no timeline, even though the FDA says you must remove it, say within a year, but I'd remove it when it's safe. If it's 2 years, fine. If it's 5 years, fine. I mean, I get it out as soon as possible. And I have a very frank discussion with the patients. Some patients just don't want their filter out. Some want it out. So it could be either way. Some I've been trying to get it out and they were like, well, I really feel very comfortable with this filter. And okay, if they don't want it out, it's okay. But I just, I discuss with them the risks and benefits because there are risk of taking them out as well, although they can be done very safely in endovascular, and these are done outpatient endovascular. I send them home the same day. They have a little neck stitch, if that.
Well, and speaking of disasters, when you're doing an endovascular removal of the filter, how do you manage when you've had the tearing of the inferior vena cava and there's hemorrhage?
Yeah, I make sure I have balloons ready. I've not had it happen, but 2 months ago, I had one that I cannot remove, and I'm debating, and she really wants it done. I tried twice. I need to use a laser. It's an off-label use, but I've been using 16 French sheath on her. First time I used a 10 French, I couldn't get it because she still had issues, and her vena cava, and I couldn't. The other thing I could do is I could plaster it, okay, against the wall, and that's it. The problem is somebody put the filter a little too high, so it's over the renal vein, almost into, and I'm thinking, oh my God, if I put that, what if she goes into renal vein thrombosis? You know, I think some of the teaching was to put it a little higher so that you get flow from the vena cava and the renal vein, so they have it right over. That is one of the hardest areas to remove endovascularly, to remove it open, to do it robotically. Doesn't matter what, and then I was like, okay, let me try endovascular. I did it a second time. She wants it out this third time. And I was like, listen, I can't, I pull so hard on it. I think I'm going to rip the vena cava. The only thing I can probably do is probably the laser. Then I need a 20 French because I didn't have a 20 French sheath at the time, and I didn't have the laser. Or I told her that she probably wanted to go to somebody else also as another option. I tried the bronchial forceps. I broke the glide wire. I've never broken an 035, but I did. With this, it actually ripped, the wire came in two, and the filter is still there. I was like, you know, so that's how much it is. Yeah, you have to have the balloon ready. And then you have to have both, you know, you have to come from the groin, common femoral vein. So you have to pull just enough, and it's not even pulling, it's more pushing. You got to push it this way, not this way. If you do this way, I've seen the whole vena cava rip. You got to push it. Yeah. And I do the tugging and pulling. I'm sorry. I don't let resin and follow. It's all by feel. It's all tactile. And I'm on the table sometimes trying to get that out. It just enough force to get it out without ripping the vena cava.
Wow. Okay. I'll let Ash introduce our next speaker.
Yeah, thanks, Sandy. Judith, nice talk.
Yeah, thank you, Judith.
Our next speaker is Jill Cole-Glazer from the Mayo Clinic, and she's going to talk to us about open and endovascular iliocaval reconstruction. Jill?
Thank you. Thank you for that introduction, and thank you to Midwest for the invitation to speak tonight. I have no relevant disclosures. So we're going to be talking about chronic venous obstruction with replacement of or reconstruction of the IVC and the iliac veins. And we're really talking about benign disease tonight. Benign obstructions of the IVC and iliac veins are commonly caused by deep venous thrombosis, as we've heard in many of the discussions so far this evening. And in the iliac venous segment, this can be due to May-Thurner syndrome. It can also be due to iatrogenic or blunt trauma, radiation or external compression from retroperitoneal fibrosis, thrombophilias, and as Dr. Lin just explained, indwelling IVC filters. Venous reconstruction or factors, Dr. Glavitsky during my training once told me that venous reconstruction is really what humbles the vascular surgeon. And that's because of the high rate of failure and the amount of detail that you have to be concentrating on to really try to make these reconstructions perfect, because there are several factors that affect their patency. The low flow and low pressure system of the veins really makes this a much more difficult reconstruction to stay patent for long term. Abnormal coagulation, a lot of these people have difficulty with abnormal coagulation coming in, which is what has set them up to have DVTs. Poor inflow from post-thrombotic syndrome, occlusion or reflux, competitive collateral flow from the chronic obstruction, and external compression of the stents or grafts that have already been placed in thrombogenic service of those stents and grafts. Surgical reconstruction of the IVC and iliac veins for benign disease has been relegated to symptomatic patients with long segment iliac vein or vena cava occlusions who either are not candidates for stenting or have failed attempts at percutaneous endovascular recanalization. These often are young and middle-aged patients that lack major comorbidities and are good risk for surgery. They have lifestyle limiting symptoms or signs of venous hypertension, ranging from C4 to C6 SEEP classification. And they must prove that they're able to comply with treatment postoperatively, whether that's long-term anticoagulation and use of compression therapy. In the late 1950s and 60s, venous reconstruction for benign occlusions using a cross-pubic venous bypass were initially introduced by Doctors Palma and Esperon in Uruguay. These were later popularized in the United States by Dr. Dale. Early failure of a cross-femoral venous bypass can occur due to small saphenous vein diameter of being less than 4 millimeters in size, poor inflow related to obstruction or venous incompetence in the femoral popliteal and deep femoral systems, inadequate cross-pubic tunneling, kinking at the donor saphenofemoral junction, or lack of an arteriovenous fistula, especially when you need to use a prosthetic graft. An 8 to 10 millimeter diameter expanded PTFE graft is used when the donor saphenous vein is inadequate. The suprapubic tunnel should emit at least 2 fingers throughout its course. If the saphenous vein kinks at the donor saphenofemoral junction, it should then be disconnected from the femoral vein with at least a 2 millimeter cuff, rotated 180 degrees, and reanastomosed to the femoral vein. The addition of an arteriovenous fistula is important if a prosthetic bypass is used. And we try to find a 4 millimeter diameter branch of the saphenous vein, or if we can't find this, use a PTFE graft and suture this between the superficial femoral artery and the hood of our donor venous anastomosis. For short segments of the IVC that need to be replaced, a spiral saphenous or femoral vein graft can be used. But autogenous vein grafts within the abdomen are prone to compression. We often use large PTFE grafts with external supported rings, ranging from 16 to 20 millimeters in size for iliocaval replacements. We try to preserve as many of the graft rings as possible, even in the region of the beveled anastomosis. In longer grafts, ones that extend the external iliac vein, we will often perform an adjunctive AV fistula. Early thrombosis of these large diameter iliac or caval grafts are uncommon. Failure occurs if there is purse stringing of the suture line, redundancy of the graft, or inadequate inflow. Anastomotic stenosis is often avoided by either beveling the graft, triangulating the suture line, and when we're tying the suture at the end of our anastomosis, incorporating at least 2 millimeters of growth factor, or otherwise known as air knotting. So this illustration shows the use of a spiral vein graft for a short segment of common iliac vein that needed replacement, as well as a venoplasty after opening up the femoral vein and performing an endovenectomy, followed by a cross-pubic vein bypass graft using the saphenous vein, and due to the multiple areas of vein reconstruction, an adjunctive arteriovenous fistula. With use of a prosthetic graft, an iliocaval bypass is best performed using a PTFE graft with an end to side proximal and distal anastomosis. The diameter of the graft is based on the size of the inflow iliac or femoral vein and of the IVC outflow. In general, 12 to 16 millimeter grafts are preferred for iliocaval. A long iliocaval or femoral caval bypass should be supplemented with the fistula to avoid graft compression. If you're going down all the way down to the femoral vein for your inflow, then we take out or dissect out and relieve the inguinal ligament to help release this and relieve any compression of the graft for the femoral caval bypass. This is an example of a case of a post-traumatic bilateral iliac vein with IVC obstruction You can see here that the patient had a double barrel wall stents placed within the IVC, extending down through the common iliac veins. Unfortunately, that endovascular case had actually failed for this patient, and the patient came with occluded veins in the occluded stents within the iliac veins in the IVC. So a femoral cable graft with an AV fistula was then performed. You can see that this graft is sewn into the IVC and then down all the way down to the femoral vein. And here is a picture of what that PTFE AV fistula graft looks like. This is another case of bilateral common iliac vein stents that eventually thrombosed, and this patient also had an indwelling IVC filter that did not help with the thrombosis of the IVC in the common iliac veins. This patient underwent an ilio graft on the left-hand side, followed by a femoral iliac graft and an adjunctive AV fistula to help keep this graft patent and flowing as well. So this is a paper from our institution that looked at factors affecting the outcome of open venous reconstructions for benign obstructions of the IVC and iliofemoral veins. They looked at 60 patients who underwent 64 deep venous bypasses. 29 of those were cross-pubic femoral grafts, 25 using vein and 4 using PTFE, 17 femoral or iliac cable grafts, 3 with vein and 14 with PTFE, and then 6 complex reconstructions. The 5-year primary and secondary patency was 42% and 59% respectively. For palmar vein grafts, it was 70% and 78%. And then for femoral iliac and iliocable bypasses, it was 63% and 86%. And for femoral cable IVC bypasses, it was 31% and 57% respectively. The only factor that significantly affected graft patency in multivariate analysis was May-Thurner syndrome with an associated chronic venous thrombosis. Endovascular treatment of venous stenosis or obstructions has become more common at our institution as expected, but open surgical revascularization is the only option for patients who fail endovenous therapy. So endovascular treatment, I'll try to touch on this really quickly because we are running out of time. We gain access distal to the lesion. This can be done through femoral, jugular, or popliteal, or a combination of these access sites. Balloon angioplasty is then performed before stenting, and sometimes you do need adjunctive thrombolysis, which was previously talked about. And then placement of a self-expanding large stent, and we'll go over what those stents are and what's being used nowadays. This is a nice example of the amount of cross-pelvic collaterals in place secondary to an occluded iliac vein, and then how those pelvic collaterals then disappear once that vein's being recanalized. This also demonstrates extending the stent across the iliocable junction, and this is really important in wall stents as the ends of the wall stent are not as strong as the middle section of it. Ensuring adequate inflow to maintain patency of the stent, and large caliber stents with increased radial force is really what's looked at for use in the venous system. This is a study that came out in 2009 and reviewed the experience of endovascular recanalization of total occlusions of the iliac veins for benign disease. Percutaneous recanalization was successful in 83% of the 167 occluded limbs. This chart shows that long-term patency, assisted primary and secondary patency rates for over 48 months for these occlusions in recanalized occluded limbs, and the cumulative secondary patency rate at 4 years was 66%. This then shows that the cumulative marked relief of pain is represented by the purple lines, as well as swelling, which are represented by the green and white lines at 3 years, was 79% and 66% respectively, stating that the quality of life metrics were significantly improved with recanalization of these occluded iliac and cable lesions. So quickly, traditionally, wall stents have been the primary venous stent, despite any IFU that states these are supposed to be used in the veins, but wall stents have some attributes that make them good for use in veins. It rarely fractures. It's able to handle curves of the pelvis and cross the inguinal ligament. It maintains strength via both radial force and compression resistance. And until recently, it was really the only stent available in diameters large enough to replicate the size of iliac veins and IVC. It does have two major disadvantages. The ends or edges of the wall stent are weaker than the main body, making them prone to collapse. And the second shortcoming of the wall stent is that it lacks precision with deployment. People started to use Z tracheobronchial stents or Z stents to line wall stents within the IVC, especially to line the edges to prevent collapse of the wall stent or overlap. We now have next generation stents. These are dedicated nitinol venous stents. The Venovo and Vici are demonstrated here, and they have received FDA approval for use in the venous system in 2019. These nitinol-based stents are self-expanding platforms, and they have improved with greater radial force, precise deployment, and definitely better radial force at their endpoints. So this is a case that involved access from both femoral veins and the right internal jugular vein to recanalize bilateral common iliac veins in the IVC that were occluded. This shows access from both femoral, access that was gained across the occlusion from both the femoral veins up into the IVC. Balloon angioplasty was then performed, and then a wall stent was placed into the IVC, followed by lining of this with a Z stent to reinforce the ends of the wall stent and overlap these areas and the overlap areas. These stents were then extended into the bilateral common iliac veins with a self-expanding Venovo stents. This shows the completion venogram with patency of the iliac veins in the IVC, and this is a schematic of what that looked like. So in summary, endovascular intervention though technically challenging, is safe with good symptom relief and has become the first line of therapy. It carries minimal morbidity and has excellent midterm patency, albeit at the cost of need for reinterventions. Open repair remains an excellent option for patients who are not suitable for or who fail endovascular treatment. Thank you.
Thank you very much. That was very nice. Your venous bypasses, I think, are like a tour de force, and a couple of the questions were related to the adjunctive AV fistula. Number one, are they permanent, or if they're not permanent, how long do you keep them in? And secondly, do you get any incidents of heart failure from the AV fistulas?
Great questions. No, they are not permanent. We do try to set these up easy access sites. We'll leave kind of elongated prolines with that are clipped so that when we get down through that subcutaneous tissue, we can follow that down to just dissect out the AV fistula PTFE graft itself and not have to really get into that groin dissection site. And so no really great answer on, is there a specific time that we take these down? We'll often follow these patients up around 4 months or so, somewhere between that 4 and 6 month mark, repeat their CT venogram at that time. If there's not a lot of that mural thrombus buildup and everything looks like it's staying patent and open, then that's a good time to take that AV fistula down, and we will do that surgically. If we think that that groin is going to be super difficult to get into, you can always access this endovascularly and leave a plug. We have done that before too. And then we haven't actually experienced in our review of our own experience at Mayo, we haven't had a patient with heart failure secondary to the AV fistula, and we really try to limit the size of these fistulas to very small, really looking at 4 millimeter venous branches versus 4 to 6 millimeter PTFE grafts to try to make them as small as possible, so that your inflow into your venous system is not big, is not really gigantic, but just enough to try to maintain patency while the patient's healing.
That's great, thank you. Then the question that I had is, you're using PTFE obviously because it's externally reinforced. I'm wondering if bovine carotids or any other sort of biologic graft might work in these instances. Do you have any information on that?
That's a great question. And no, we actually don't have any experience of using either cryopreserved grafts or bovine carotid. You know, really, we've gone towards using PTFE with the external support, especially for replacing IVCs. And I'd say the majority of our experience for replacing IVC is from malignancy disease. And with just replacing all of the organs back in, you can see how that could crush if you've done a spiral vein graft, as opposed to kind of that really thick walled 20 millimeter externally supported PTFE graft. So I don't know if that would end up just crushing up in the belly, but if it would be different down as a cross pubic graft.
Great, thank you. Sandy, back to you.
Well, I think that wraps up our speakers, and I think we've gotten to all the questions that have been placed. I wanted to again thank our sponsor, Penumbra, for sponsoring this January webinar, and thanks to all of the speakers for some excellent talks. There were some questions. This is being recorded, so it'll be available in playback later on. And thank you to all the participants. And good night.
Thank you.
You all. Thanks. Bye-bye.